Welcome, everyone. Thank you for joining us. This is part 3 of our series of briefings on methane mitigation and health. This briefing is about methane mitigation in the waste sector and benefits for health from strategies that can tackle methane. We have interpretation available for Spanish and Spanish to English, or English to Spanish, sorry. If you would like to use interpretation, click on the globe at the bottom of your screen and then choose the language that you'd like to listen to. I'd like to invite everyone to introduce yourselves in the chat with your name, your organization, maybe where you are geographically, and anything else you'd like to share. And then as we go along, if you have questions, please go ahead and post your questions in the chat. We may not have time for, we haven't allocated time for a proper Q&A segment, so our speakers will take a look at the chat and respond to your questions there. So without further ado, I would now like to turn over to Amy Rowland. And I'm sorry, I think I didn't even introduce myself. Why don't I introduce myself? I'm Jenny Miller. I'm the Executive Director of the Global Climate and Health Alliance. And having introduced myself, let me now introduce Amy Rowland, who's a Senior Analyst for Environment and Natural Resources at Apt Associates. And Apt Associates partnered with us to develop a series of reports on methane mitigation and health opportunities for methane mitigation in 3 main sectors: energy, food, and waste. So Amy is here to talk about the findings of our report on methane mitigation and health in the waste sector. Over to you, Amy.
Thank you, Jenny. So I am hopefully sharing my screen. Hopefully you can see the slides, but please let me know if you can't. So thank you again, Jenny. Happy to be here today. So again, Amy Rowland, I'm with Apt Associates, and in this role, I work at the intersection of climate and waste. So that includes leading Apt support of the U.S. Environmental Protection Agency's Global Methane Initiative for the municipal solid waste sector. So when we're looking at the waste sector, we are talking about those human-caused methane emissions in both municipal solid waste and wastewater. So in total, the waste sector accounts for approximately 20% of global human-caused methane emissions. So municipal solid waste, that's our trash generation and disposal at the household and commercial level, that represents about 12%. And then the other 8% from wastewater. So as you'll see on the slide here, the common thread is organic waste. So methane is produced when that organic material or waste decomposes anaerobically. So for municipal solid waste, that's going to be food waste, yard waste, paper waste in a dump site or a landfill. And for wastewater, that's the collection and treatment of human waste, and it really depends on the methods employed for that treatment. In the interest of time here, I'll be talking specifically about some of those health impacts and solutions in the municipal solid waste sector, but of course, I want to add that disclaimer that wastewater and human waste management has major implications for sanitation, quality of life, and spread of disease. So again, that organic material that's collected as municipal solid waste, that accounts for almost half of the waste stream worldwide, and in some places as much as 70 to 80%. So compounding this current challenge that we're already seeing with our waste generation, the World Bank estimates the total solid waste generation will increase 70% by 2050. So then with methane, in addition to being the short-lived climate pollutant, which is how we've been talking about methane a lot, especially the last couple of COPs with things like the Global Methane Pledge, we're finding, and this is what we talked about in those reports that Jenny mentioned, that methane also contributes to ground level ozone formation. So ozone is an air pollutant that can cause short-term health impacts, including asthma attacks and headaches. And then over the long term, that exposure can impact overall respiratory health. So it's important to recognize that methane emissions in the waste sector do not happen in a vacuum. There are other health hazards posed by landfills and dump sites. So there are co-pollutants that exacerbate poor air quality and health outcomes. So for one example that you're seeing on the slide here, it's from Mumbai in India. Students and parents were worried about these fumes and odors from an illegal dump site nearby a school. The parents came together and they hired a team to test that indoor and outdoor air quality at the school. And the results showed high concentrations of ozone and then other air pollutants, including sulfur oxides, nitrogen oxides, and formaldehyde. So in addition to these other co-pollutants or air pollutants, we also know that methane gas at landfills can cause or exacerbate waste fires. And then with that burning of waste is released black carbon and particulate matter, which can also have health impacts when inhaled. So those waste fires also cause burns for workers or the community members that live on or near these landfills or dump sites, and of course cause damage from impact or shocks from explosions. So these are all examples from just this year. And I found this headline from a landfill fire in Indonesia recently where they outright said that methane was a suspected cause of this landfill fire. So lastly, other impacts from improper solid waste management include inhalation exposure from other unsafe waste practices such as intentional open burning, so not just the accidental fires that are caused at landfills, but intentional open burning, for example, of e-waste to reclaim those metals. There's also groundwater contamination from the landfill leachate. We've seen landfill slides, which can be caused by the unstable dump sites or even those fires, which can impact the stability and have buried residents and workers that live and work close to or in those dump sites. And then, of course, there's plastic pollution that clogs drains and that can lead to stagnant water and flooding, which provides breeding grounds for mosquitoes. So looking at all of this, methane from landfills and dump sites are part of a larger problem in the solid waste sector, and that's inadequate solid waste management and overconsumption in what we call a linear society, one where we take resources, we make products, and we use them, and then we dispose of them as waste. We're not recapturing those materials in the value chain. So the most important strategy to employ is making the short and long-term transition to what we call a circular economy that prioritizes reducing waste and utilizing waste as a resource. So addressing the methane emissions from municipal solid waste and wastewater through this overall system improvement is crucial to combating climate change and addressing existing public health concerns. So I won't read out all of these solutions here, and you can find more information in the reports that Jenny mentioned, but the health community, the waste community, and advocates can support for waste sector methane mitigation strategies by communicating with policymakers, holding authorities accountable, and especially facility operators of dump sites, landfills, holding them accountable as well. And luckily, a lot of the technical solutions for methane mitigation in the waste sector are feasible, they are cost effective, and they have those benefits of resource conservation, emissions reductions, and improved health outcomes. So I will stop there. Please do check out the reports for additional information on these solutions. And I'll be monitoring the chat for questions, and I'll drop my email in as well.
Great, thank you, Amy. And I believe that we've posted the link to the GCHA web page that has the reports in the chat. So you can, if you've not had a look at the reports, you can find them there. Okay, Amy, maybe you could stop screen sharing. And next we are going to hear in a pre-recorded video from Ruth Springer of Healthcare Without Harm, and she's going to talk about healthcare waste and methane.
Hello, my name is Ruth Stringer. I'm the International Science and Policy Coordinator for Healthcare Without Harm, and I'm here today to talk about methane and medical waste. When people think of medical waste, they tend to think of infectious waste, the syringes, bandages, and so on, that have the potential to spread disease. Less attention is paid to the organic material that's produced in a hospital, food, and pathological waste, which is organic material of human origin. Operating theatres produce a small amount, and blood banks have to reject donations that have proven to be infected with HIV or other blood-borne pathogens. Far more comes from the maternity department. A placenta weighs around 600 grams, and with 23 million births in India in 2022, that adds up. However, this is dwarfed by the amount of food waste generated in those healthcare facilities that have catering services for their patients and staff. Based on our work in South Asia, we estimate that about 300 grams is produced per inpatient per day, and it can represent up to half by weight of all the waste produced in the hospital. Because healthcare waste strategies are focused on this infectious material, not methane emissions, most of the food waste is sent to landfill. In places with poor municipal waste management systems, it isn't collected quickly enough and attracts flies, rats, and other disease vectors, so it does pose an infection risk after all. Most placentas and similar waste are sent for incineration or pit disposal, and pits, of course, emit methane. A lot of fuel is needed to burn placentas, so hospitals with small on-site incinerators burn recyclable materials like paper and plastic to keep fuel costs down, emitting carbon dioxide and air pollution in the process. As part of Healthcare Without Harm's global team, my search for sustainable non-burn waste treatment and disposal technologies led me to investigate biodigestion with our strategic partners in Nepal, HECAV 360. We consulted with the World Health Organization on safety aspects, and Narayan Zande, a biodigester expert working in Nepal at the time, designed the biodigester for this very special waste stream. The most important issues we had to address were, first of all, maximizing retention time for potentially infectious material to ensure that bloodborne pathogens were destroyed, eliminating potential routes of infection, even in a worst-case scenario, balancing nutrient levels for pathological waste, which is higher in nitrogen than the usual plant material, and managing the methane that is produced. The solutions that we found were, first of all, to use a two-stage digester with one smaller chamber feeding into a second larger one. The placentas were fed into the first chamber and most of the food waste into the second. This way, the potentially infectious material was digested twice and had an average time in the system of up to 6 months. Since most bloodborne pathogens only last a week or so outside the body, this gives a very large safety margin. Putting the bulkier food waste into the larger second digester, which has a shorter retention time, also reduced the amount of space that was needed. We agreed with WHO experts that no solids from the digesters would be used as fertilizers, although this is common in agricultural systems. Our hospital systems are connected directly to the sewer, so that materials that were put in never need any more handling, eliminating potential reinfection routes. Nutrient balancing was achieved by adding a certain amount of food waste with the pathological waste, given nitrogen levels that the bacteria could cope with. And finally, the methane management. The simplest and most effective method is to burn the biogas, either to heat water or in the hospital kitchen that generated most of the waste in the first place. Burning the biogas converts the methane into carbon dioxide, which has a lower climate forcing potential. Depending on how you calculate it, the climate impact of the carbon dioxide is up to 40 times lower than that of the methane. Based on the costs of cooking gas in Nepal, we estimated the digesters produce biogas with a value of $20 for every ton of waste. There are financial savings also in avoiding disposal costs for the waste. Other benefits include reduction in infection and nuisance from having large amounts of organic waste untreated on hospital campuses. There are now several successful hospital waste digesters in Nepal, and the design concept has been replicated in Tanzania and Madagascar. In some places, such as India, where the biomedical waste disposal rules prevent biodigestion of pathological waste, there are barriers to further uptake. However, this is a technology that deserves to be used far more widely and could almost eliminate methane emissions from healthcare waste. Thank you for listening, and if you have any questions, I can be reached at rstringer@hcwh.org. Goodbye.
Surab, over to you.
Thanks, Jenny. I'm Saurabh from the German Development Corporation, GIZ. I'm sharing my screen. Is my screen visible? Yeah, okay. So Amy had already set the grounds talking about the health impacts. I'm talking about how to eliminate those health impacts through appropriate monitoring and community engagement with sustainable waste management. I'll be talking about a project where we experimented. The project was to have national appropriate mitigation actions. I'm talking about a city in a state of in the province of Uttar Pradesh in India, which is Varanasi, also known as the spiritual capital. It has a population of around 12 lakh, around 1.2 million, and around 0.25 million floating population every day, because it is a spiritual capital of the country. A city being not so big has 5 zones and 90 jurisdictional wards, generating around 750 tons. Of this, approximately 38% is wet waste and rest being dry waste. When we talk about processing setup, it has 3 biomethanation plants, 5 tons capacity each, but was catering to only 3.58 tons a day. 25 tons of dry waste particularly was sent out for waste to energy pilot facility, and approximately 38% was going out to composting at Karsada. Door-to-door collection services only started in December 2016. We started our project in 2018. Approximately 1,42,000 of waste is disposed to a dump site every year. City waste characterization was done to understand what is it that can be done in a city, how a material recovery facility can be set up, how waste can be diverted towards more processing. And we found that approximately 20% of the waste was ideal for turning them down to biomethanation or composting units. And there was a higher scope to have dry waste recyclables recovered, which facilitates not only in recovering the dry waste and diverting them from disposal, but also makes organic waste available, more organic waste available for composting and biomethanation. There are many health linkages linked with appropriate processing and management of waste. Waterborne diseases, it leads to breeding grounds, also has chronic and acute health impacts. It slows down your childhood growth. There are risks associated with liver damages and kidney damages as well. We did an experiment at the site. I'll be talking about this experiment. The experiment started with selecting 5 wards where we wanted to experiment if we make more rigid and more IECs around, so information and capacity building of households, will we be able to achieve better segregation and more people participating in the segregation of waste from the source itself. Before that, we did an audit to understand what is it going on, how are people getting engaged, or how are people situated. We did a study where we covered 625 households in these 5 zones, 100 hotels and restaurants, 13 educational institutes, and 400 shops and offices. What we found out, I'm not going in details, but what we found out was waste was often thrown out on streets by residents because they did not subscribe to door-to-door collection services offered by the urban local body. And why was this? Because people responded that the services provided were rather irregular. They could not rely much on urban local body services, so they don't want to pay and they don't want to participate in that service. Though it was the ULB who was not able to make it forcefully for the people to participate and to provide the services. They were not panelized, I must say. So I'll not go much in details, but the experiment that we did, we had the infrastructure set up. We asked the urban local body to put in place people which will go regularly for door-to-door collection. They collect waste in a segregated manner. We did IECs. We interacted with people around these 5 zones. We asked them like what are the issues, how they can do better. We even did daily monitoring of this waste collection, assessing every household whether it was giving waste or giving it segregated or not. Then if they were not giving segregated waste, the reason for that, or if they could do better. We also did pilots around, like every month we used to have a competition, and whichever household in a colony was giving segregated waste, the maximum number of times in a month will be awarded by the ward councillor. The waste sanitary staff who was collecting waste was also honored, because we wanted them to be more participatory, and we wanted them to be honored with the type of work that they do, and so that they don't make their services irregular, and they do it daily. Look at the bar graph on the right hand side. Also, this period was also the initial phase of COVID. We did face challenges while going out at site, and our monitoring also went down in month of July. You can see on the bar graph, you see that the red tag going down because the monitoring went down because of COVID. There were restrictions for movement. But if you look at the graph from August till November, you see that the number of people giving segregated waste, the blue bars, went up. Clearly indicated that with the ICs, the number of people giving non-segregated waste went low, and number of people giving segregated waste went up. This was the influence that we saw. The numbers, in terms of numbers, we saw that approximately 40% rise we saw in participation. This was due to infrastructure being in place, people being engaged, they being made more aware of giving segregated waste. What we found as a result, like there, we also assessed that with this segregation in place, replicating in the city, we have a potential to reduce greenhouse gases as well. We did a baseline assessment using SWEET tool, and thereafter we also did an estimation of how much reductions we can have. Cumulatively, we figured out that by year 2030, we'll be able to reduce somewhere around 1 lakh metric tons of CO2 equivalent, and this will go on increasing as we reduce the amount of waste going to landfills and process more amount of it. So overall, the concept of source segregation could be strongly interlinked with health and economic benefits by demonstrating direct impacts and benefit to public. The project did not stop here itself. The work, since what I'm talking about is 2019 and 20, but we went ahead. Nowadays, the project has also been converted into other more projects by GIZ. And currently, we are also in phase 2 of the earlier NAMA project, as well as new project, which is managing organic waste in India, which again targets on streamlining organic waste, not only looking at the broader picture, but also looking at the particular streams of waste like flour waste, coconut waste, fish meal waste, sawmill waste, these particular streams of organics, which can be linked for better employment, group involvement, self-help group creations and employment, as well as looking at more diversion of waste towards better usage. There are also digital portals coming up by the Ministry of India, where GIZ is helping them, where it is also like allowing the solid liquid processing facilities called SLRM centers to even offer compost that they have to the buyers who can take it from the city. So that's the organic waste project that is currently going on, looking at banana waste recycling, experimental centers, organic waste streams at hotels or some educational institutes. I'll not go in details of what these are, but the idea is to reduce more waste, to engage more people, and to allow better usage of the organic streams as much as we can. Let us be together to make future sustainable. Thank you.
Thank you so much for sharing that really interesting work, and it's very interesting to hear kind of in that kind of detail about how a project like that rolls out. So thank you so much. Okay, we just have a few minutes left. So we would like to now get your ideas, everyone who's joined us, about where the health community could most, jump in and make a difference in, pushing for waste strategies that mitigate methane and benefit people's health. So if you could just respond to this poll and pick the strategies that you think are most promising for the health community in particular to get involved with. And then we'll give like a minute or two for people to take a look at the options here. Do we have some results yet, Milena?
Yes, we do. Are you able to see them?
Yeah. So it looks like the option that is most appealing to people or seems most promising is integrating solid waste management and water sanitation and hygiene and their health impacts and mitigation measures into the country's nationally determined contributions and into their health national adaptation plans. Others that rise up are adopt a national strategy to reduce organic waste in landfills. Yeah, those seem like the top two that people think are most promising, with about equal responses on the others. Okay, well, we'll wrap in just a moment, but before we wrap up, I wanted to invite you all to participate with us in developing some resources for the health community to focus in on particular policies around methane mitigation and health. So after this is the last of our briefing series, we'll send out a survey to everyone who participated in these briefings, participated in our earlier workshops, or have expressed an interest in the intersection of methane and health. And that survey will ask, taking the input that we've already gotten from these briefings, will ask folks to identify sort of the top 5 policy areas that you think the health community should work on. And then we'll draft policy briefs for initially the first 2, and then this month, and then later some of the others that have been selected. And once we've developed a draft, we'll want to circulate those back to you and get your input and feedback into those policy briefs so that we can really develop together policy briefs that would be useful not only in waste but in energy and food systems for people from the health community who want to get involved on these issues. So we hope you'll respond to that survey and identify the most exciting and promising policies that you think the health community would really want to engage with. And then we hope that you'll bring your expertise and knowledge to helping us develop those policy briefs and make them as strong and useful as possible. Thanks very much for joining us today, and we hope to see you again.